டாக்டர் பாவை என்னாச்சுன்னு தெரியல.
லிங்க் அனுப்பிச்சிட்டேண்ணா அவங்களுக்கு வேணா அவங்க லிங்க் திருப்பி அனுப்புவாங்க உங்களுக்கு.
ஒரு மறுபடியும்
அவங்களுக்கு யாரா கால் பண்ணுங்க if you know her number. எனக்கு அவங்கள யாரும் தெரியாது.
வந்து கோயம்புத்தூர் பீடியாட்ரிக் சர்ஜன் மேடம்.
ஓகே சர்ஜனா? ஓகே
பீடியாட்ரிக் சர்ஜன் கோயம்புத்தூர்.
அப்ப ராஜேந்திரன் சார் கால்
இல்ல PhD ல she is a professor of pediatric surgery மேடம்.
ஓகே
பஸ்
உங்களுக்கு இப்ப அனுப்பிச்சேன் அவங்க நம்பர் அவங்க இது.
ஒன்னும் ப்ராப்ளம். நீங்க என்ன பண்றீங்கன்னா எனக்கு டாக்டர் பாவை மேடத்துடைய செல் நம்பர் எனக்கு அனுப்பிவிடுங்களேன். எனக்கு அனுப்பிவிடுங்க பேசுறேன். சரி
ஒரு ஜெயந்த்
சொல்லுங்க மேடம்.
சென்னையில இருந்து பிரசன்டர் கமலி வந்து அவங்களுக்கு லிங்க் வரலங்கறாங்க. நான் உங்களுக்கு அனுப்புனேன்ல.
நோ ப்ராப்ளம் மேடம். ஜஸ்ட் அட்டெண்டன்ஸா ஜாயின் பண்ண சொல்லுங்க, ப்ரோமோட் பண்ணிக்கலாம் மேடம். அட்டெண்டன்ஸா ஜாயின் பண்ண சொல்லுங்க, ப்ரோமோட் பண்ணிக்கலாம்.
சரி அட்டெண்டியா ஜாயின் பண்ண சொல்றேன். ஹலோ அம்மா அட்டெண்டியா ஜாயின் பண்ண.
பிரசிடென்ட் சார் குட் ஈவினிங். இன்னைக்கு பிக் பாஸோட பர்த்டே.
குட் ஈவினிங் டாக்டர் மேடம்.
டாக்டர் ஸ்ரீதேவி நாராயணோட பர்த்டே சார்.
டாக்டர் ஸ்ரீதேவி
ஹேப்பி பர்த்டே மேடம்.
ஹேப்பி பர்த்டே. பாட்டு பாடுங்க சார். நீங்க பாட்டு பாடுங்க.
அவங்களே பாடுவாங்க சார்.
வீடியோ ஆன் பண்ணு ஸ்ரீதேவி.
மேடம் நான் வீடியோ ஆன் பண்ற மாதிரியே இல்லையே.
ஓகே தெரிஞ்சிருந்தா கேக்கே அனுப்பிச்சிருப்போமே.
யூசுவலா தூங்குற மாதிரி
நான் வீட்ல ஜாலியா உட்கார்ந்திருக்கேன்.
சரி கண்ண மூடின்னு தூங்குற மாதிரி பண்ணிட்டு இருக்கியா?
ஸ்ரீதேவி ஹேப்பி பர்த்டேங்க.
Thank you sir.
ஸ்ரீதேவி மேடம் ஹேப்பி பர்த்டே.
Thank you sir president sir.
many more happy returns. வாழ்க வளமுடன்.
நன்றி
சார் வணங்குகிறேன் சொல்லணும் சார்.
மேடம் அந்த சாரி
ஸ்ரீதேவி மேடம் வந்து என்னோட வயசு குறைவுதான் நினைக்கிறேன்.
சும்மா சொன்னேன் சார். ஆமா
கண்டிப்பா குறைவு சுரேஷ்.
இல்ல அவங்க பிக் பாஸ் அதனால சார்.
ஏன் தாக்ஷாயினி
பிக் பாஸ் வந்து உருவத்துல
செயல்ல தான் மேடம் கவலைப்படாது.
மனசு உடல் உயிர் எல்லாத்துலயும் பெருசு.
சரி ஆரம்பிச்சிடலாம் மேடம். ஐ திங்க் யூ கேன் ஸ்டார்ட்.
ஆரம்பிக்கலாம். யா ப்ளீஸ் ஸ்டார்ட்.
Good evening everybody. After a break of a couple of months, actually we are back to our end of the month program, the 4C series, which is mainly targeted at addressing some of the common practical problems which are likely to encounter. Today we have another interesting topic on cervical lymphadenopathy. So let us start the day with the pediatrician's prayer by our treasurer, Dr. Dakshani. Over to Dr. Dakshani.
குழந்தை மருத்துவனை நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றோம், நல்லனவற்றை உள்வாங்கும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள்.
Thank you. Thank you. As we all know, this program on 4C series is one of the presidential action plans of Dr. Cervical, and it's his brainchild. Mainly, it's about discussing clinical case capsules in a very crisp manner. So this is our 8th such event, and So may I now request our President, Dr. Cervical, to say a few words and then kind of restart the proceedings.
Very good evening to all. Respected Secretary Dr. Tirumurugan, Treasurer Dr. Dakshayani, President-elect Dr. Ramesh Babu, Balashankar sir, past President Dr. Ramesh Babu, and the Academy of Pediatric Sciences, as mentioned by our Dynamic Secretary Dr. Tirumurugan, who is always behind all these academic programs, coordinating very nicely. And this is the ninth program which is being conducted today under the able leadership of the coordinator, Professor Dr. Rajendran sir, and Dr. Ashwath, who are the brain behind this 4C series, clinical case series. And I think we have started off very well this entire year. We have conducted this program in a very nice manner, selecting all the common as well as the very important, relevant, practical problems in pediatrics clinical setup. And we are very happy that we have the moderators, Professor Janani Madam, Professor Dhanalakshmi, and Professor Pavai Madam, who have joined, sparing their valuable time on this holiday occasion. Professor Sridevi Madam is there, and many other faculties are there, as well as the presenters are here. So I'm very thankful to each and every one of you for taking IAP TNSC's various activities, especially the academic programs like 4C series, PG teaching program, and so many things in a nice manner. And my appreciations to each and every one of you, especially Professor Rajendran sir, who is very much involved in this activities for so many years. And once again, I take this opportunity to wish you all the best learning experience today. Thank you very much for this wonderful session.
Thank you, sir. Without wasting much time, I may now call upon our academic coordinator, Dr. Rajendran, to take over the session, please. Over to Dr. Rajendran.
Yeah, thank you, Dr. Aturu. And respected our dynamic President, Dr. Suresh Balan sir, and our dynamic Secretary, Dr. Tirumurugan, and Tachani Treasurer, and President-elect Dr. Balashankar, and President 2021 Dr. Ramesh Babu, and my friend Dr. Ashwath Turaisamy. It is 8th 4C series, and actually it's well taken by all our members, and it's really useful for the clinical management aspect. This is our main motto of this starting this 4C series. And I really thankful to today's moderator, Dr. Janani Shankar Madam, and Dr. Dhanalakshmi, Dr. Pavai, who is a pediatric surgeon. And without wasting time, I think we can start the program. Since Ashwath is out of station, I request Dr. Janani Shankar to take over as a moderator and as well as deliberate this session. Madam, please take over, Madam. Janani Madam.
Yeah. Yeah, okay. I think thank you for the opportunity, TNSC team. I think we'll move on to the first presenter. Tirumurugan, you can ask the first presenter to present.
Who is the person ready now? Dr.
Dr. Sanjeevda, if she is ready, or Dr. Ilanidhi.
Yeah, whoever is ready, please start. Request to the presenters, make it very crisp, just 4 slides only. And we may stop you in between, and then we'll have the discussion in between too.
Dr. Ilanidhi, are you ready?
Yes, ma'am.
Yeah, share your screen.
Sir, I can't share. Only hosts can share this meeting like that.
Yeah, you can share now. You can share now.
Okay. Sir.
Are you able to share now, Doctor?
Yes, sir. Wait. Wait a minute. Sorry. Sir, you can ask some other 2%, sir. I will give the time. I will ready to.
Dr. Edwin. Dr. Edwin, are you ready?
Yes, sir. I'm ready, sir.
Please.
I will share my screen. Yes, sir.
Yeah, it's visible, doctor. You
But the
can start.
visible.
Put
Yeah,
slideshow
please
and
go to
start.
slideshow.
1 minute. So,
Start. Yeah.
ma'am. Good evening, respected professors and faculty members of IAP team. So, my name is Jayant and I am from PG resident from Christian Medical College, Vellore. So, I am up here with an interesting case. So, let's go into this case. So, present mostly a 4 years and 1 month old boy from Odisha presented with chief complaints of swelling in right since first week of April 2023, and he was presented to us in the middle of June. So just before the presentation, he had a history of fever for just 3 days. So these are the two main chief complaints. So coming to the history of illness, so child is a previously child. There was no other comorbidities. So initially swelling was started in the first week of April. Just before the onset, there was a history of right ear pain and discharge for only 3 days. Followed by there was an insidious and gradual progressive onset of swelling in the right post-auricular region. There was no history of contact with TB. There was no history of any weight loss or loss of appetite. So he was for this above complaints. He was consulted with the local ENT physician, and he was diagnosed as a basal abscess. And he was started on initially oral antibiotics, especially amoxicillin, for a period of 1 week. Followed by that, a child had a initial period of resolution, but there was a minimal resolution only attained. So followed by a period of recurrence was also noted. So again, he had a second visit to the doctor, for which antibiotics were upgraded to higher order. That's especially oral inner was given for a period of next 10 days, even though the swelling was not yet subsided completely. So he was went ahead with the local pus culture, which grew Escherichia coli, and sensitivity showed it was sensitive to amikacin and cefepime, and bloods which was done outside showed leukocytosis. So this is our child. So clinically, swelling was located in the right post-auricular region, and on examination, mild tenderness and warmth was noted. Size of the swelling was approximately 5 cross 4 centimeter, and mild erythematous was also noted, and it was soft in consistency and multi-lobulated in nature. Skin over the swelling was normal, and mild shyness was also noted. There was no ulceration noted. Coming to the investigation part, when the child presented to us, initial blood showed eosinophilic leukocytosis, and the consecutive reports also showed the persistent eosinophilic leukocytosis, along with the rise in the inflammatory markers, especially CRP, and rise in IgE also. And blood-borne viral markers as well as creat reinforcement were within normal limits. And local imaging of the swelling showed multiloculated necrotic collection with internal echoes noticed in the posterior triangular region. And the largest size of the lymph node was about 1.5 centimeter at the level 3 region. And bilateral parotid as well as submandibular glands were within normal limits. And pus culture came out to be negative for fungal TB PCR, expert PCR, MZ, and biopsy was also showed inconclusive results. Even GJ aspirate also showed inconclusive results, and only the bacterial culture showed MSSA growth, that especially methicillin sensitive growth, and everything came out to be negative. So coming to the summary of our case, this is a 4 years and 1 month old boy presented with chief complaints of swelling in the right post-auricular region for about 2.5 months, and also history of fever just 3 days prior to the swelling, and he is a previously well child, no other comorbidities. On examination also, mild tenderness and warmth was noted in the post-auricular region over the swelling, and it was about 5 cross 4 centimeter. So considering the above findings, so these are the differentials we could consider. So first is possibility of TB lymphadenitis. Second is the local bacterial infection, especially staphylococcal infection, and final is a Kimura disease. So we may wonder what's this Kimura part, and why we consider as a in our differential cards. So that's the point. So Kimura, since due to the calcification, especially in the head and neck region and also in the post-auricular region, also with peripheral blood stored eosinophilia. So these were the 2 points which clinched us to the point Kimura.
Okay, I think stress.
Yeah.
Okay, finish. One more slide only, no? Yeah. How many
No,
more
still some 3 to 4 slides are there. Totally 15
No,
slides.
I think you stop there. Before we go into all that, no?
Sure.
So, going back to the presentation, it's a previously boy who presented with right post-auricular node with preceding history of fever and also some ear discharge. Am I right?
Yeah, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am.
So, Dhanalakshmi.
Yes, ma'am.
Yeah. So, I mean, what
So
would be your thought process? I think it's just a simple
duration is
infective
2.5 months. So primary just staph causing this adenitis is less likely. So there is something happening. So 2 months there is no fever also. So acute infection is less likely. Whether it is a chronic infections like tuberculosis or non-tuberculous mycobacteria, on top of it, only 3 days there was a history of ear pain and fever. And that pus culture grew MSSA. So I will not put the blame on staph aureus. So what is underlying etiology, we need to find out. Whether there was similar history prior?
Was there a similar history, doctor?
No, ma'am.
He said he was previously well. No.
Previously, also, no other complaints.
Was there a history of contact with tuberculosis or something?
No history of contact.
No history of contact.
So usually, if there is a cervical lymph node swelling with ear discharge, we tend to think of histiocytosis also. But only 3 days duration, again, it is less likely. So we have to proceed further.
So it's some underlying problem with an superadded secondary bacterial infection. Yeah.
Yes.
Okay, doctor, proceed. Yeah.
Sure.
Make it very simple. Yeah. Don't go too much into theory. No theory. Okay.
Okay, sure. So mainly for the pathological aspect of diagnosis is, so the lymph node biopsy especially showed lymphoid hyperplasia along with peripheral eosinophilia, and also vascular proliferation was also noted. The key differentiating feature from Kimura, the other close differentials are especially ALPE, that is angiolymphoid hypereosinophilia. So in which we could appreciate the same pathological findings. The differentiating feature is here the vascular proliferation will be in the normal pattern, that is endothelial cells usually be flat, and there will not be any cytological atypical features will be noted. But in case of ALPE, similar kind of lymphoid hyperplasia and eosinophilia will be there, but the endothelial cells will be in hobnail pattern, and it's also protrude into the vascular lumen. So this close differentials we need to clinch to this point. Along with that, in the year of the pioneer for this Kimura disease, it was originated in the year of 1937, especially Kim and Set they are the Chinese medical personnel. So initially they coined this based on this clinical findings, they coined this term as eosinophilic hyperplastic lymphogranuloma. Following by a period of after 10 years, a Japanese medical personnel named Kimura et al. Coined the term of on the unusual granulation combined with hyperplastic changes of the lymphoid tissue. So these were the brief literature behind this disease. So coming to the pathogenesis part, the main pathogen is immune dysregulation. That is abnormal response to either maybe an infectious or allergic trigger. So which is presented by the CD40 helper cells to the mantle zones of lymphoid tissue. Further, transcription factor GATA3 is activated, which will activate the B cells and plasma cells, and which will help in the switchover of the immunoglobulin IgE production, and which will stick up onto the mast cells and help in degranulation, which results in the following clinical features. And also in between the cytokines also play a vital role, especially IL-4, IL-5, TNF-alpha, and etc. So coming to the management part, there's no definite management for this particular disease. So there are varying results we noted. So a lot of immunosuppressive agents have been tried along with antihistamines, but definite outcome is not yet appreciated yet. So till now, that's an increased recurrence rate following a surgical excision. So approximately about 60% recurrence rate are there. So we should be cautious in following up once we diagnose the child. So our index still we have started with the oral corticosteroids at a dose of 2 mg per kg. So initially we have prescribed for a BD dose for initial first 2 weeks, followed by once daily for the next 10 weeks. So we must note the red flag signs in the cervical lymphadenopathy. So it must be in the.
I think you stop there,
yeah,
doctor. Yeah. So,
What
Dr.
about
Pavai,
MSSA?
yeah. Dhanlakshmi, you want to tell
What
something?
about MSSA?
Did you
Ma'am,
treat the MSSA or not?
No, ma'am. Actually, initially this FNAC was done outside, ma'am. So we consider that it may be a contaminant. So the MSS may be
No,
there.
you
And
only
also
did
after
pus culture MSSA. First it was E. coli, it is contaminant. But next pus culture, you put MSSA.
Initially we treated with the IV antibiotics, ma'am, and it has responded well. And also the repeat blood culture and as well as showed no growth, ma'am. And also child was clinically stable, no history of fever after a presentation, ma'am.
The common infections which cause cervical lymphadenitis is it is staph, it could be MSSA or MRSA along with staph pyogenes. These are the two infections which can cause secondary adenitis. Okay, so I think this child has to be given 2 weeks of total antibiotics.
Antibiotics also, yeah. So, Dr. Pavai,
yeah,
ma'am, are you there?
Yeah,
ma'am. Yeah.
Can you hear me? Okay.
Yeah. So, ma'am,
good evening.
your experience with this Kimura, how often have you diagnosed Kimura? Or, I mean, we have normally, more of Kikuchi and Rosai Dorfman and all that we have diagnosed. How often have you come across Kimura, ma'am?
My question first is, how is the baby now?
Yeah, must be doing well. She's on steroids.
Yeah, ma'am. He's on steroids, ma'am. So last follow-up, he came to us in the month of September. Swelling size was reduced. So approximately now it's in 2+3 centimeter. A child is clinically stable. There was no further increase in the swelling size and no other complaints also. He's doing better.
Okay. What about ultrasound? What was the ultrasound finding? Did you do an ultrasound?
Yeah, they've done. He presented.
Yeah, ma'am. It showed some multi-located internal echoes. Yeah, ma'am. Yeah, ma'am. Yes,
and when you aspirated, was it pus or what was it?
Pus is done. Yeah, ma'am.
See, the basic thing is, I don't know too many. I mean, Kimura's disease would have been the last one in my mind. Okay, as a surgeon, when there is pus, when there is pus, my first thing would be take out the pus. So, and then maybe curate it and send it for biopsy. So, I mean, it is a very good diagnosis which you made with your eosinophilia and your FNA and your biopsy. But my approach would have been initially just as any other abscess. It could have been, I mean, there has been no other node, only one group of nodes. So my approach would have been a drainage first, a curettage at the time of the drainage. And of course, then if I have proven it's a Kimura, of course, I would go ahead with the treatment which you have suggested.
Yeah, sure.
Yeah. The Dr. Satish, Loganathan Satish, his hands was up. You have anything to add, Dr. Satish?
Yes, ma'am. The child, when the child came, like already the child was treated with the course of
Please
oral
introduce
antibiotics.
yourself. You're from Vellore, is it?
Yes, ma'am. I am Satish Loganathan, looking after the clinical immunology in child L3. So this child, I have seen the child first when the child came, already the course of antibiotics was given. The parents' main complaint was persistent lymph node. In the past, I have seen Kimura disease. That's why I recognize this child as first as a differential diagnosis Kimura in the OP file. Even in the outside, one of the CBC profile, they didn't provide the eosinophils. So that was the suspicion. So immediately we ordered a
Doctor, eosinophilia made you think
that was
of
one of
Kimura,
the differential weakness.
Yeah. Okay.
Yes, ma'am. So, and especially the posterior cervical region, the post-auricular region is the one of the classical sites.
Common, yeah. Okay.
The Kimura disease the patient present with.
Okay. Yeah. I think that was a good case. I think the key points from this case is previously well child, isolated post-auricular node, and with eosinophilia as a clue, which made you think of Kimuras, and node which was persisting even after adequate dose of antibiotics. And so you went ahead and did a biopsy, pus drainage and biopsy, and histopathology confirmed your diagnosis of Kimura. And currently on steroids and on follow-up, doing well. Is that?
Yes,
yeah. Okay.
Yeah,
anyone else has anything with this case? Otherwise, we'll move on to the next case.
Madam, one doubt. The child had ear discharge. Is it the common site post-auricular area to have the lymphadenitis following ear discharge?
No.
What is the drainage area for the ear discharge?
Usually it's not the drainage areas.
But before
It's
ear
not
discharge,
related,
only
I
this
think,
will-
yeah.
No,
I know, it's just a
want to know,
coincidence, yeah.
Are
just
they
a
related
coincidence.
or they are separate things?
No, I don't think it's related. Because how many children we see with AOM and CSOM?
Yeah, we don't
Very
see
rarely do they have a post-auricular node.
post-auricular.
Yeah, it's very, I mean, I think it's just an associated finding that he had. Or maybe they looked more deep into the ear because the child had a persistent node and they found some discharge. Was the discharge very obvious, doctor, or was it coming out, or I mean, significant, or you just?
I don't know. As per parents, it was just a serious discharge.
Okay, fine.
Very mild in nature only. That.
Okay, okay. You cannot label it as otitis. Yeah.
Yeah.
Okay. So if there are no more questions, I think we move on to the next patient. Yeah. Tirumurugan, you can ask the next presenter to present. Who's the next one? The girl.
I think Dr. Sanjeevita. She can.
Yeah. Please share your screen, doctor. The previous speaker, I think Edwin, you did a good job. Thank you. That was a good case. Yeah.
Sure. Thank
you. Sanjeevita.
Share your screen, doctor, please.
Hello, Sanjeevda, can you share your slide, please?
I think if she's not able to do, we can move on to the next person, sir.
Tirumurugan, sir, can you open the slides? Can you share your slides?
Thiru?
Yeah.
Sanjeevita slides?
Slides share பண்ணணுமாமா?
I sent
I think they should
evening.
send one set to you. I mean, one copy.
Yeah, I sent one set to you, Dr. Thiru, this evening, this afternoon.
Raju sir must have sent it. You just
1 second.
Maybe ask her to send it again now so that he can share it.
No, it has been sent. Just 1 second.
Yeah. Okay, good. Sanjeevita, you can start presenting. Dr. Sanjeevita, are you there? She's there or not? Yeah.
Can we ask? We'll ask Dr. Deepa to present, and then maybe she can come back to her.
Yeah, I think you can minimize and keep it.
Yeah.
Dr. Deepa?
Yes, ma'am.
Yeah, please share your screen, please.
Yes, ma'am.
We have 6 presenters. We can't be wasting time with this sharing business. Yeah, put slideshow and start. Yeah. Yes.
Are the slides visible, ma'am?
Yeah, visible. Please start. Yeah.
Good evening, everyone. I'm Deepa Susan Thomas. I'm doing my 3rd year PG from CMC Vellore. Presenting Miss A, a 12-year-old girl from Vellore who presented with complaints of fever for 2 weeks, swelling in the right side of neck for 1 week, and dry cough for 1 week. She was apparently well till 2 weeks back when she started developing high-grade intermittent fever with chills, documented temperature of 102 degrees Fahrenheit. There was no history of evening rise of temperature or night sweats. Following which 1 week later, she noticed a swelling in the right side of the neck, which was gradually increasing in size and was tender to touch. She also had dry cough, which was gradually progressive with no fast breathing. There was no history of throat pain, dysphagia or ear discharge. No other swellings were noted. There was no history of loss of appetite, loss of weight, night sweats or bony pain. There was no history of contact with tuberculosis. On examination, she was febrile, not in distress. Vitals at admission, temperature was 101.4 degrees Fahrenheit. Heart rate was 100 per minute, blood pressure of 100/70 and respiratory rate of 22 per minute. Anthropometry, her weight was 38 kg between 0 and +1 Z-score. Height was 145 centimeter and BMI was 18. There was no pallor, icterus or edema. There was a 2 into 2 centimeter tender right cervical lymph node in the posterior triangle, a 2.5 into 2 centimeter tender firm right axillary lymph node. Other systemic examination was normal. There was no hepatosplenomegaly. So summarizing, this is a 12-year-old girl who was presented with high-grade fever for 2 weeks, followed by right cervical swelling and dry cough for 1 week. And on examination, there was tender lymphadenopathy in the cervical and axillary region with no hepatosplenomegaly. So at this point, our differentials were infections primarily, followed by malignancy and rheumatological causes. In infections, we thought of infectious mononucleosis, rickettsial infections, typhoid, tuberculosis, HIV, and brucellosis. In malignancy, we considered leukemia and lymphoma, and our rheumatological differentials were incomplete Kawasaki disease and systemic lupus erythematosus. Investigations at arrival, her hemoglobin was 12, total count of 4,000 with 62% lymphocytes and 5% monocytes and elevated ESR and CRP. And serial investigations showed a progressive leukopenia with monocytosis and elevation of the inflammatory markers. Tumor lysis workup was
Doctor, you stop here, doctor.
Yes, sir. Yes, sir.
Deepa, yeah. So I think we'll ask the experts to discuss this case. Now, Dhanalakshmi.
Yes. So sorry, the age of the child?
12-year-old, ma'am.
So
Adolescent girl with
adolescent girl has a lymph node in two non-contiguous sites. So it's basically, it looks like a generalized lymphadenopathy, but without organomegaly.
Yes,
it doesn't look like acute infective process, no? So both the sites.
And fever also was significant.
Fever was significant. No, acute cervical lymph node. It is not an acute infection in the cervical lymph node as such. There is something happening in the axillary node also. So it is some generalized process which is happening. With leukopenia, so it is progressively falling counts with lymphocytic equivocal response. So I will think more of chronic infections like a TB as my first differential, TB, non-tuberculous mycobacteria, and Kikuchi SLE as next differential diagnosis.
IMN, yeah, you can keep IMN also in mind because
this is no hepatosplenomegaly, there is no exudate in the throat.
No rash, no
rash, nothing.
And usually you have a high counts in IMN, not such.
A 12-year-old child, why you consider Kawasaki as differential diagnosis here?
Kawasaki maybe.
That was
one of your
one of the last differentials, ma'am.
But usually in this age group, we will not think of Kawasaki, no?
And more than that, two nodes, no? Two nodes.
Typhoid, rickettsial diseases also without hepatosplenomegaly, no third spacing. Clinically, it doesn't fit in with that infections also. And viral is less likely. So either
brucellosis also.
Chronic infections we can consider subacute bar chronic infections, or it is a non-infectious cause like Kikuchi, SLE.
Yes, ma'am.
So we'll hear more from her. Yeah. Thanks, Dhanalakshmi. We'll get more information from her. Yeah. Go ahead,
Ma'am. So tumor lysis workup done was negative. Infectious workup including blood culture was sterile. Vidal and Wheel Felix was negative. Bloodborne virus screening was negative. TB workup including MANTO, GJ expert and MJIT was negative. EBV IgM was negative. ANA showed 1+, but complement levels were normal and anti-dsDNA was negative. As she continued to have fever spikes, bone marrow examination was done, which was negative for malignant cells. She persisted to have fever.
Biopsy, you proceeded with bone marrow.
Sorry, ma'am?
Before lymph node biopsy, you did bone marrow.
Yes, ma'am. For this child, yes, ma'am.
Or you should have done both at the same sitting, no? When you give anesthesia for a bone marrow.
Negative, we will not proceed with dsDNA also, no?
And more than that, peripheral smear study is more important, doctor. You've done tumor lysis workup, but peripheral smear, we didn't hear anything from you.
Peripheral smear did not show any atypical cells.
Yeah, so peripheral smear study, you should put it in the investigations, okay?
Sure, ma'am. Yes,
Such children, I think peripheral smear study is very important, even before your tumor lysis workup, okay?
Yes, ma'am. Sure, ma'am.
Yeah, okay. And always know it's better to combine a bone marrow and a node biopsy at the same sitting. When you give anesthesia for bone marrow, normally that's what we do. We combine both because you You can get some information from the node, which is obviously staring at you in both two sides.
Yes,
Yeah, that's why Dhanalakshmi was more, concerned why biopsy was not done and bone marrow was done. Okay,
Sure,
let's
ma'am.
hear from
Yes,
you.
ma'am.
Yeah, go ahead. Yeah.
As the fever persisted, we proceeded with a lymph node biopsy, which showed reactive lymphoid follicles in the cortex with paracortical expansion and patchy necrotic areas containing karyorectic debris surrounded by histiocytes and macrophages with crescentic nuclei. There was paucity of neutrophils and eosinophils, which was consistent with necrotizing lymphadenitis pathognomic of Kikuchi disease.
Classical presentation.
Classical.
So always around 10 to 12 years children, unilateral cervical lymphadenopathy with falling counts, always first diagnosis should be Kikuchi. So many times we tend to see girl children, we tend to have a close follow-up. It may be a pre-runner of SLE also. So we must have a close follow-up of these children.
Yes, ma'am.
Yeah. We can hear something from Dr. Pavai. Ma'am, your experience with Kikuchi, madam? Dr. Pavai? Okay, I think you continue. Ma'am will join and you can ask her. Yeah.
Sure, ma'am.
I think Satish Kumar sir wants to say something.
Satish? Satish is there, is it?
He has raised his hand.
Satish? He's also not there. Okay, I think they're very confident that Deepa will manage all the questions.
Okay.
Okay, Deepa, you go ahead. Yeah.
In the ward, we had started her on treatment with injections ceftriaxone, amikacin, and doxycycline. After lymph node biopsy report, diagnosis of Kikuchi disease was confirmed, and she was started on TAP prednisolone 1 mg per kg per day for 2 weeks, which was gradually tapered over the next 4 weeks. She became afebrile and was symptomatically better.
Why amikacin for lymph node
Why
swelling?
ceftriaxone, amikacin?
So
Initially fever for 2 weeks, we had kept rickettsial also in mind, ma'am. So doxycycline was
okay.
That is okay. Doxy agreed.
is acceptable, but amikacin,
Amikacin is not required. Okay, we are in the antibiotic stewardship week closely coming. So amikacin, I think you should have. I mean, not required.
Kikuchi, directly you start steroids or you will first try NSAID first? No.
for this child, we had started on steroids, ma'am.
Usually it's self-limiting. Most of the time they are self-limiting.
Yeah, self-limiting or with the NSAID, usually
they
it
do
results.
well. Yeah. Yeah, only
Janani,
if the fevers.
Janani, can I answer?
Yeah, Satish, please.
Janani, this child's main thing is leukopenia. Okay. Initially before the biopsy, amikacin was given because we are suspecting like a febrile neutropenia, waiting for the biopsy report. And second thing, after the Kikuchis came, steroids were started because the child has got fever, lymph nodes, and leukopenia.
Yeah, steroids, no problem. Yeah. No.
Yeah.
The only
That's
thing is
because
we
of
were
leukopenia
wondering
also
about
worrying.
amikacin. Yeah.
Counts was dropping, so we are a little worried. That's the reason we gave steroids for this child with Kikuchi's disease.
Yeah. That is definitely acceptable.
Kikuchi will always,
we were only
most of the time, will have leukopenia. So.
Yeah.
Sure.
And the other thing is Kikuchi is a forerunner of malignancy. SLE. So I think you should, SLE and malignancy, you have to have a close follow-up on this child. Yeah. So we are having all rare things first because Velour were the presenters first, I think. Okay. I think the child is okay and better. Okay. Thank you, Dr. Deepa. So we had one Kimura and one Kikuchi. I think let's have some common things now.
Dr. Sherry?
Shajita is ready. Shajita is ready. Yeah? Shajita.
Sanjeevita, I'm ready.
Sanjeevita.
Yeah. Sanjeevita, please start. Yeah.
Okay.
You can try to present, doctor.
Okay.
Yes. Good. At last. Start. Slideshow, please. Yeah.
Good evening, everyone. I'm Dr. Sanjeevita from Krishna Maternity Home and Pediatric Center. Let us go into a case. I'm presenting a case of 7-year-old child, female child, who came with swelling in the right side of neck for the past 2 weeks and fever for the past 10 days. On probing, the swelling in the right side of the neck was for 2 weeks. It was gradually progressive and it was not associated with pain. Fever was of low grade lasted for 10 days. Fever was intermittent, not associated with chills or rigor or night sweats. There was no diurnal variation. It relieved with medication. There was no history of weight loss or abdominal distension. No history of cough, cold. There was no history, positive history of TB contact. No past history suggestive of measles or pertussis. The child was immunized till age. On examination, child was febrile. She had pallor. There was no icterus sinus clubbing or pedal edema. There was a right cervical mass just below the angle of the mandible, 5x4 centimeter. It was not warmth, but tenderness was present. It was a single mass. It was mobile. It was soft to firm in consistency. There was no sinus or scars visible. There was no scalp or skin infections of the face or dental caries or any oral ulcers. Initial blood investigations, CBC showed leukocytosis with neutrophilic predominance, and CRP was negative, MANTO was negative, chest X-ray was normal, FNAC was suggestive of granulomatous lymphadenitis. So we proceeded with excision biopsy, where there was an abscess cavity was there, and the pus was drained, and the lymph nodes were enlarged and mattered 5x4 centimeter. And the pus culture, pus gram stain showed few gram positive in cocci and bacilli. Pus culture showed no growth. AFB and NAT were negative. Treatment part, before the HPE report was available, we started her on amoxicillin clavulanic acid, and child was discharged. Child was advised to follow up with biopsy report. The biopsy report showed complete caseous necrosis and many necrotic epithelioid granuloma, few Langerhans cells, and suggestive confirming the diagnosis of tuberculous lymphadenitis.
Yeah.
So we started the child on ATT.
Okay, stop there, doctor. Yeah, so this is the common thing, but only thing is, I think it took, I mean, you did an FNAC and then you did a biopsy and then you got the and all the other corroboratory evidence was not available for you. That's usual thing. Dana, you want to comment on this? Yeah.
So usually as per NTP also, whenever there is a suspicion of tuberculous lymphadenitis, we can first start with antibiotics and reassess. So they have correctly started an antibiotic, but as far as possible, better to avoid FNAC. Excision biopsy should be the gold standard. So many times we tend to miss the diagnosis.
Do not waste
Recently
time
also
with
we had
FNAC. Yes.
FNAC showed granuloma. They started on ATT. 3 months they gave ATT, but swelling was persistent. So they came here. We did an excision biopsy. It was suggestive of lymphoma. So as far as possible, we should avoid doing FNAC. Excision biopsy should be the gold standard. And most of the time, we also may not be able to find out gene expert positivity. But granulomatous adenitis, most of the time, ATT was start. Like we tend to start ATT, but definitely we have to look for evidence of caseation. So granuloma doesn't equate to TB. So there can be infectious causes other than TB, and there may be suppuration, like other rare infections can also give rise to granuloma. Rarely they say sarcoidosis and lymphoma leukemia, they also cause sarcoid-like reaction leading to granuloma formation. So granuloma does not equate to TB. And again, granuloma, MANTO positive. So many times 30 to 40% of our children tend to have MANTO positivity. So granuloma plus MANTO positivity, again, they tend to start an ATT. That should not be happening. So have a close look at the histopathology, discuss with our pathologist to look for caseation, to look for typical evidence of TB. And if we are convinced, and in fact, non-tuberculous mycobacteria, they say we are missing so many cases of NTM also. So in children, it is also more common. The only treatment for non-tuberculous mycobacteria is just an excision. There doesn't need a chemotherapy. So we have to try to look at the difference between whether it is TB or non-tuberculous or whether we are missing
culture
something.
Is very important.
Yeah, culture also should be important. So
what was the X-ray of this child? How was the X-ray of this child, doctor?
X-ray was normal.
Was there normal, no hilar adenitis or anything?
Normal.
So she didn't have any.
Why this child was presented is because the peripheral blood picture, the CBC was a bit misleading. Child had neutrophilic leukocytosis.
That happens.
Short history, and it was absolute neutrophil count was very high. We thought it was a just pyemic
infective
abscess,
adenitis.
less than 15 days duration. We thought so. So the initially, not many people will subject themselves for excision biopsy, especially in a setup like us. So we had to convince them.
We can give ATT. If it is, we can give start with antibiotic. Definitely, if it is a tuberculous lymphadenitis, it's going to be persistent.
What I am asking, madam, whether I am justified in starting ATT in this child with just Langerhans giant cells and the biopsy picture.
Yeah, this child had caseating necrosis, sir. So this is justified.
Yes, matters, sir.
Caseation. Matted nodes, caseation, Langerhans giant cells.
Local TB person. Because we have to inform, we are supposed to inform the local TB person before starting ATT. And he was not of the opinion to start ATT in this case because you do not have any 100% corroborative findings in this. So we started with the great debate. That's why this being put in this forum.
Definitely, this child warrants ATT. And
because this is a common scenario which normally we peripheral pediatricians face here.
Madam, what is the CBNAT positivity in node like this, nodal tuberculosis? What is the percentage of CBNAT positivity?
40 to 50% only, sir.
Around 40 to 50, 40 to 60 maybe, yeah.
You mean quantiferon gold TB, is it, madam?
No, CBNAT.
CBNAT, okay. Gene expert, we could not do.
But culture actually better yield than, I don't know what. AFB culture, we are able to pick up more than CBNAT.
Why quantiferon gold TB is not approved in India, but in UK?
No, it is like MANTA only, no, sir. Just tell you the exposure. It doesn't tell you whether it is a disease or infection.
Just says that the child is exposed.
Less endemic areas, it's being approved. In UK, we give certificate.
Expensive, yeah.
UK, where
there is, as you say that, you just need one negative test. Manto, they feel it's a lot of invasive procedure, so they do quantiferon gold.
Madam, how common is the NTB, madam? Non-tuberculous mycobacteria, such thing in this thing in India?
Not picking up, but of late, so many literature they are telling NTM is also more common. They say age is around 7 to 10 years, mostly submandibular, parotid lymph node, preauricular lymph node. These are the common site. And enlarged lymph nodes with violaceous hue, they are mentioned typical picture. Of late, in the last 1 year, we had 3 cases of NTM, which was grown in culture actually. But excision biopsy is the only treatment. We are just excise the node and follow up. No treatment we have started, yes, sir.
But if there is lung involvement, then you'll have to treat.
Yeah, disseminated disease, definitely we have to start.
Disseminated, we have to treat,
Localized disease.
Is culture the only mode? Is the culture the only mode of diagnosis of NTM?
AFB smear will be positive. Gene expert will be negative.
Gene expert will not pick it up, so
negative. So usually in TB, if smear is positive, gene expert has to be positive. No, it's a PCR base. So definitely
smear positive, gene expert negative, you should suspect.
Suspect non-tuberculous mycobacteria, and all cases TB AFB culture has to be sent.
Has to be done.
Within 2 weeks.
Dr. Pavai ma'am has raised her hand.
Yeah, like you said, madam, the first important thing is FNAC in lymph node should be avoided because we have missed a lot of cases of lymphoma when we do just an FNA. Number 2, gene expert and culture has to be sent. Number 3, whenever it is not responding to your ATT, think of non-mycobacterial tuberculosis. So that's the, and because you have to do an excision. So,
yes. Thank you, ma'am. Thank you, Raju, sir. It was a good case, and I think not easy to do it in a
It's a common thing, but dilemma to start ATT.
No, but 2 weeks duration, you always tend to think it's infective, and you try to juggle with the antibiotics rather than. And I mean, one more point, sir. The history, I think you should probe and ask about intake of organic milk and also contact with animals, because brucellosis can present like this. Can present with node and fever will be persisting. So brucellosis is one thing. Brucella IgM, or you can do a culture. Both ways you can do. Of course, doxycycline, if you start, they're going to improve. But I think for the postgraduates, I think history in a child with lymph node, history taking is very, very important. Exposure to animals, recent history of travel. Sometimes when you have an eschar, the local lymph node will be enlarged. So you should also look at an eschar closer to the node. Isolated node and fever, you always look at an eschar in the post-auricular region or in the scalp, because we've had children. Cat scratch disease also is common. Yeah. Cat scratch, I think monocytosis is characteristic. No? Yeah. That's what the pathologists say. Okay. Thank you, Raju sir and the presenter. Move on to the next case if there is no other question. Thank you, Pave madam. Yeah. We'll move on to the next case. Who's the next one, Thiru?
Dr. Sherin, is it?
Sherin, yeah. Dr. Sherin, are you there?
Or Dr. Kamali?
Whoever is ready, please present. Ilanidhi also is there. Ilanidhi also.
I'm there, ma'am. Will present.
Okay, whoever is ready, present. Who's that? Who's going to present?
Dr. Kamali is ready. Dr. Ma'am Kamali, I'm ready, ma'am.
Kamali, okay. Kamali, come on. Kamali, present. Share your screen, doctor.
Yes, ma'am. Ma'am, is my screen visible, ma'am?
Yeah. 1 minute. Yeah, visible. Open your, yes.
Visible?
Yeah, visible, audible. Go ahead.
I'm Dr. Kamali, final year PG from Chettinad Hospital and Research Institute. My title is Beneath the Surface, a puzzling case of deep neck space infection. A 7-year, 6-month-old female child came with the presenting complaints of cough for 1 week, swelling over the right side of the neck for the 2 days, and fever for 2 days, and difficulty in swallowing for 2 days, and inability to turn the neck for 2 days, for which she got admitted in our hospital. So coming to the history of presenting illness, child was apparently normal before 7 days back, after which she developed a dry cough, which was not associated with any sputum or blood, which is more in the night with no aggravating and not relieved by any medications. And history of swelling over the right side of the neck noticed by the mother, which was initially small and which gradually progressed to the present size, and which was associated with pain. Out of 10, the child gave a scale of 7 to 8 pain scale, which was moderate to severe in intensity, which was continuous with no aggravating and relieving factors, and history of difficulty in turning the neck. And she also had complaints of fever for 2 days, which was intermittent, low grade in nature, not associated with any chills or rigor, which was relieved by medications, and history of throat pain and difficulty swallowing. There was no history of any discharge from the swelling, no history of change in voice, running nose, or ear pain. There is no history of any prolonged cough, shortness of breath, hemoptysis, or any evening rise in temperature. No history of vomiting, loose stools, abdominal pain, abdomen distension, or jaundice. No history of loss of consciousness, convulsions, and headache. No history of loss of appetite, weight loss, easy fatigability. No history of swelling noted elsewhere in the body, and no history of radiation exposure. The child took treatment in the OP clinic for 2 days, and child was started on oral antibiotics and antipyretics. And since there was no improvement, child was admitted in our hospital for the above mentioned complaints. On admission, vitals were stable, and clinical features showed oral cavity. She had no dental caries or no ulcer. Coming to the tonsil, right side grade 3 tonsillar enlargement was there. Anterior pillar was congested with no exudate, and uvula was deviated to the left side, and left tonsil showed a grade 1 tonsillar enlargement with anterior pillar congestion with no exudate. And on lymph nodes, right anterior cervical lymph nodes was palpable, and with a size of 2 × 2 centimeter, which was warmth and tenderness present, had a smooth surface and was firm in consistency, and left cervical lymph node was also palpable, of size 1 × 1.5 × 1.5 centimeter, with no warmth or tenderness, and no other lymph nodes were palpable anywhere else. So coming to the local examination, she had a solitary globular swelling on the right lateral aspect of the neck of size 4 × 4 centimeter, which was warm, and tenderness was also present, and which was smooth in surface, firm in consistency, and restricted mobility was present. Trans-elimination test was negative, and the skin over the swelling was normal. Carotid pulsations was present over the normal position, and systemic examination was normal. And this is a child's picture. She had torticollis of neck also. And coming to the investigations, we've sent a complete blood count which showed neutrophilic leukocytosis, and C-reactive protein was elevated, and ultrasound neck was done, and CECT showed hypoechoic lesion present as noted in the picture, and blood culture was sterile. So coming to our differential diagnosis, we initially suspected as peritonsillar abscess, also parapharyngeal abscess or retropharyngeal abscess. So coming to the treatment.
Stop there, doctor. Stop there.
Okay.
Yeah. So again, this is not uncommon. We do have children coming with parapharyngeal, but the fever was not very high grade, you mentioned, no? Usually these children are very toxic, and the fever is usually high grade and they are very toxic. And you mentioned torticollis came after the node, is it?
Yes, ma'am.
Yeah.
After this.
Yeah. So this is again not uncommon. It's usually infective. Dana, you want to add something to this?
A typical looks like a retropharyngeal or parapharyngeal abscess only. But only thing is, you mentioned about the discrepancy in the size of the tonsil. Right was grade 3 and left was grade 1.
Yeah.
Yes, ma'am.
So was there any membrane or anything in there? Follicles or membrane?
No, ma'am. There was no membrane.
Should not be any difference in the, if it is a normal physiological, see this age tonsil should be enlarged, but how to explain the difference?
And also told that uvula is shifted.
Shifted to
suggestive of like a Quincy-like picture.
Yeah, tonsillar abscess.
Yeah, peritonsillar
peritonsillar abscess.
What was the ultrasound? What was the ultrasound, ma? Ultrasound picture, ma?
Sir, ultrasound, they showed a hypoechoic lesion of size 3 × 2 centimeter present on the...
Where hypoechoic?
Ma'am, in the lateral aspect, ma'am, of the neck with bilateral hypoechoic...
in the lymph node or in the tonsil area?
Ma'am, not over the tonsil, ma'am. There was a swelling over the right lateral aspect of the neck, ma'am.
Any hepatosplenomegaly? No.
No, ma'am. There was no organomegaly, ma'am.
Okay, fine. How did you manage this child?
Ma'am, initially the child was taking on OPD basis of oral amoxiclav, ma'am. After admission, we started on the child on injection ampiclox, ma'am. And we did a CECT, which showed a ill-defined peripherally enhancing lesion with multiple enlarged lymph nodes, ma'am, which suggested right parapharyngeal and prevertebral space extension, likely abscess. And after starting her on IV antibiotics, gradually on day 2 of admission, her pain started decreasing, and she was able to turn her neck, and gradually she started her oral intake also improved, ma'am. And blood culture was sterile, and the swelling size also decreased. And on day 8, we did the CBC, which showed the normal counts.
Yes.
And
she didn't require surgical intervention, is it?
No, ma'am.
Okay, about ampiclox, what dose did you use?
It's a combination, or separately you gave ampicillin and cloxacillin?
No, they've given a combination.
Together we gave, ma'am, ampicloxacillin.
Actually, it is
because
not an
that's
approved
not recommended at all. Yeah,
it's not an approved combination. Both the doses you cannot have. Why
if you give separately, it's fine. Yeah,
ma'am, to cover staph aureus.
See, staph, there are so many organisms you need to cover here. Parapharyngeal or retropharyngeal abscess, non-typhoid.
Gram negative also.
everything needs to be covered. So the ideal choice is maybe here it is MSSC, so you're able to get away with it. But generally, without knowing what it is, we generally start the child on
ceftriaxone and clindamycin.
Yeah. That should
and
be.
your Chettinad
Ampiclox,
Hospital is a private setup, no? Why are you giving Ampiclox?
it's not an approved combination actually.
Ma'am, since it came in a single together combination, we gave.
No, the drug, the dose of the drugs, you
dosage will not be
dosage,
adequate.
and usually, preferably approved drugs should be used. Okay. So there are so many off-label combinations available. For example, ceftriaxone plus Albac, so many things are available. But still, preferably use a drug which is approved combination.
You will not achieve the correct, drug dosage if you use combinations like this. No, it will be an inadequate coverage, and you're not doing a surgical intervention also. All the more you should give strike her with a good dose of antibiotic. Otherwise, you may need to do.
And total duration here is 2 weeks.
2 weeks.
Till the resolution, you give parenteral, then switch to oral.
So you didn't get any pus for culturing, no? You didn't do any drainage.
No, ma'am.
So you assumed it's staph and you treated.
Yes, ma'am.
Clinically, she was improving. So, but the only thing is, everything was fine except for the choice of antibiotic. The choice and the duration should be adequate. And sometimes, we do these type of children. We do try 48 hours of IV antibiotics, like Nadashmi mentioned. Usually, we give ceftriaxone and clindamycin. But if the child starts improving, then we don't do anything invasive. Sometimes they just improve. Sometimes they do need intervention in the form of ENT surgeon has to intervene, or a pediatric surgeon has to intervene. Dr. Pavai, are you there, ma'am?
Pavai, madam?
Yeah, because this is again a pediatric surgeon's area.
Yeah,
Not
can you hear me?
easy. Yeah.
Yes, madam.
Yes, ma'am.
Madam,
So,
your role of your pediatric surgeon is such acute inflammatory swelling in the neck.
I've been going through it. The discussion has been very interesting. But the only point which I would like to make is all these deep-seated abscesses, you have to be very careful. You have to treat them by medication as suggested, but if not improving, will definitely need surgical intervention. This is a parapharyngeal, so it's okay. But a retropharyngeal or a Ludwig's, you have to be very careful because the signs and symptoms are very less, but they go in for a glottic edema very fast. So surgical intervention, you'll have to keep them, may have to keep them in ICU also, because you can see sudden
airway is very important.
Airway, and you may not be able to intubate because the glottic edema is there. So surgical intervention may be the only choice. So deep-seated abscess, take care, do a CT and surgical intervention early if necessary.
I think surgical intervention is the first choice, if I am correct.
Yes.
All along we had been following such children.
Yes.
And I think that should be given the first mark.
Madam, the CT or MRI, which will be the ideal choice, madam, such cases? CT or MRI such cases?
MRI is better for soft tissue, but the only problem is it takes a long time. These children are very sick. So usually we do a CT and get away fast. So,
CT is enough.
CT is enough. CT is enough.
Okay. I think, thank you, doctor. That was again a good case. Only thing is, antibiotics, I think you'll have to go and read up again. The choices may not be suitable for this child. Okay?
Thank you, ma'am.
Yeah.
You have Dr. Sharon here. Dr. Sharon?
Sharon, yeah.
Yes, ma'am.
Yeah, Sharon, you can start presenting, Sharon.
Yes, ma'am. Good evening. I would like to thank IAP for giving me the opportunity. 4-month-old infant brought by his parents whose reliability of information is fair, with chief complaints of difficulty in turning head to right side. Child becomes irritable and fussy when attempted so. Child prefers to keep head towards left side. History of presenting illness. Child was apparently normal a week ago, after which mother noticed difficulty in moving head freely towards right side. History of cough and cold for 5 days. History of rhinorrhea. No history of fever, trauma, any native medication. No history of vomiting. No history of any drug intake. No history of any seizure. No history of decreased limb movement.
Stop there. Go back to that slide. Why seizures and why decreased limb movement? What did you, what were, to rule out what?
Intracranial infections, ma'am. Torticollis might be a presentation.
Intracranial infections. Okay, then for that sensorium is more important than limb movement, no?
Yes, ma'am.
Because no, I don't think if you talk about limb movements in a child, when you think of meningitis, first thing you should think is the sensorium rather than the limb movement. No, so ICT signs and symptoms only is more important. Vomiting, I agree, but seizures also I agree, but limb movements may not be correct. Okay, yeah, that's for your exams. Yeah.
Any brain herniation might cause compression.
Ah, okay. So the child will not come to you with a neck node if the child is herniating. Okay, go ahead. Yeah.
Firstborn male child, normal vaginal delivery, birth weight 2.75 kg, present weight 6 kg, cried immediately after birth, no ICU admission, immunized up to age, developmental milestones appropriate, exclusively breastfed child. On examination, child was irritable, taking DBF, prefers to be fed on one side, torticollis plus on the left side, no pallor, no icterus, no cyanosis, right cervical region, cervical lymph node of size 1.5 cross 2 centimeter, 3 to 4 nodes palpable, firm in consistency, tender and erythema present, no other nodes palpable. Length 60 centimeter, weight 6 kg and head circumference 41 centimeter. Peroral examination was normal. Sternocleidomastoid muscle examination, no stiffness. Cervical vertebra examination was normal. Other system examination, no abnormality detected, and no other lymph nodes were palpable. BCG dose given and evolving scar was present. Our DD was sternocleidomastoid muscle tumor, cervical bone deformity, unilateral brain herniation, drug-induced dystonia.
Stop there again. So summarize your history and tell the differential diagnosis. Little confusing now. Just summarize your history.
4-month-old child was
4-month-old, yeah. 4-month-old, okay, fine.
Apparently normal a week ago, after which mother noticed difficulty in moving neck towards right side. And child was irritable and was difficult to be fed since past 1 week. This was a presenting.
Fever was not there.
No history of fever, ma'am. Only history of URA was present.
So it was that's why it's thought of a local pathology. Okay, now you go back to your differential diagnosis. Differential. Sternocleidomastoid tumor, cervical bone deformity.
But all are chronic conditions, which here the problem is only acute
unilateral brain herniation, my God. That's not, not the usual clinical thing. Drug-induced dystonia.
Can I have a clarification?
Yes, ma'am.
Yeah. She told me the torticollis was on the left side, but the node was on the right side. Am I right?
Yes, madam. Yes, madam.
Yeah. That's what she said. Yeah.
Yeah. So it's a bit confusing because what we usually teach is the node causes inflammation, makes your head tilt down towards the same side.
Yeah.
So
okay. Tilt to the same side. Yeah. Confusing. Okay. So why did you think of cervical bone deformity, clipple fail deformity? These are all things that should have been there from birth, no? 4 months of age, 1 week duration. Why did you think of all these things?
Madam, sorry for this from Dr. Balaji from Dharmaburi, madam. Actually, for this case, it is not differential diagnosis. Any child came with torticollis, usually these are the differential diagnosis, but here the node caused the torticollis. This is a little bit rare presentation, differential presentation. That's why you put the slide like that. It's not for the particular case.
Okay, I was thinking of this child only. Okay. See, always talk about the particular child, no? Differential diagnosis should be to that pertaining child. Yeah.
Okay, madam. Okay, madam. Okay.
Yeah. Otherwise, no, it misleads the audience. Yeah. Go ahead, doctor. What did you do with this child?
In CBC, total count was elevated. The neutrophil predominance, HB was 10 gram per deciliter, and peripheral smear showed neutrophilic predominance with toxic granules. CRP was positive, and X-ray chest was normal, and X-ray neck, AP and lateral view was normal. USG neck multiple.
CRP level?
18 gram per deciliter.
18, more than 6 is abnormal.
Yes, ma'am.
Okay.
USG neck, multiple discrete cervical lymph nodes of size 2 x 1.5 centimeter present on the right side of the neck. USG abdomen normal. Course in the hospital as child had multiple lymph nodes and was irritable. Child got admitted, treated with IV antibiotics, amoxiclav with paracetamol, then switched over to oral amoxiclav, which was continued for 14 days. As child had multiple lymph nodes and child was fussy, FNAC done and the sample was sent for pathology for isopropyl alcohol fixation, and heat fixation was done for Ziehl-Neilson technique. Report was obtained was non-specific reactive adenitis. AFP stain turned out to be negative. And child clinically improved with IV antibiotics. Torticollis improved. A repeat USG neck showed resolution of lymphadenitis.
Okay. Very unusual for a 4-month-old to have node causing torticollis and resolving very well with just 3 days of IV antibiotics. Are you sure there was no history of fever at all in this child?
Mother did not give, no, there was no documented fever during the course of
After admission also no fever, is it?
No, ma'am.
Yeah.
Obviously, the child had no fever, madam. The child came with only torticollis only. So we evaluated fully and found that no cause was identified. Then finally, the only cause identified was only lymph node, which was resolution after antibiotics. So that's why we presented this case here to just highlight in there, madam.
Okay,
yeah, you have managed it properly, but only thing is why FNAC was done. This age TB adenitis or other causes are very, very less unlikely, no?
Yeah.
So here doing
if there was fever, we would have thought of Kawasaki in this child.
Fever, but
fever and node with, FNAC is not required, Balaji.
Madam, actually, yes, as you have pointed out, it's correct, madam. But just we should not want to miss some other diagnosis. That's why then FNAC.
After 2 weeks reassess. If the node passes, then you can do an excision biopsy.
You said that child was improving so well with antibiotics. You can wait. Yeah.
After 2 weeks, if the node passes, then we can do an excision biopsy.
Age is not
So
this age we normally don't do an FNAC.
Any other things other than this acute process, usually suppurative or it's going to be a Kawasaki. Most of the time we admit a suppurative adenitis. Next day the child will develop all the features of Kawasaki.
Only thing is this child needs to be kept under close follow-up. At this young age, developing adenitis significant enough to cause torticollis, you'll have to probably have a close watch. Sometimes if there is a recurrence, you may have to do immunoglobulin profile and other things. Yeah. Immune deficiency like SCID and all can present like this. Yeah. So you have to have a close watch on this child. X-ray showed a thymic shadow or not?
Yes, ma'am.
No,
thymic shadow
madam. X-ray was normal only.
Normal. Thymic shadow was present. Yeah. That's what these children know. 4 months old with node or significant infection in a young child. Have a close look at the X-ray for a thymic shadow. Look for lymphopenia. All those things you should. We have picked up so many SCIDs like this, I think Dana will agree. Just like that, they come for bronchiolitis, they come for a gastroenteritis. The only thing that should make you suspect is severe infections requiring hospitalization or IV antibiotics. I mean, at an young age, you should always look at all these things, and SCID can just present just like any other infection. But I think we should have a close watch and try not to miss SCID because it's treatable with bone marrow transplantation.
Yeah. Madam, madam, your take on torticollis at this age, madam. Your madam.
Yeah, I'm here only.
Yeah, your take on torticollis at this age, about in the infancy, early infancy, presenting, if it is acute or if it is chronic.
A 4-month-old with acute lymphadenitis, we have seen and it has resolved. But then I would want to be very sure that it's not a branchial cyst or something else just got infected and is resolving. That's my take on this case.
Yes, agreed.
Stenomastoid tumor also.
Yeah. Stenomastoid tumor, usually not at 4 months. It's usually around about 6 weeks and it's at lower region and it's not very tender. It's not very tender. So
yeah, it's a painless torticollis.
Yeah.
Agreed. Okay, Shireen, that was a good case again. Only thing is go back and look at the counts and keep a close follow-up on this child. Okay?
Yes, thank you.
Yeah. Yeah, thanks, Balaji. That was a good case.
Thank you, madam. Just we highlighted this case only for some rare presentation. And second thing, FNAC can be done as a office practice even by pediatrician. And after taking FNAC, after fixing the isoprolol, we can send for pathology department. And after each fixation, we can send for microbiology department. Can be done by the pediatrician itself. No need to refer the case to other centers, madam. That's also we want to highlight in this case. Thank you, madam. Thank you.
And one general thing is, whenever you have a cervical lymph node swelling and posted for biopsy, always better to have a chest X-ray and look for the mediastinal node involvement. You have to rule out mediastinal node involvement. Otherwise, sometimes it may compromise. When you give anesthesia, it may cause some problems.
FNAC பண்ணணுமா வேண்டாமா மேடம் கடைசில?
FNAC currently it is not justified, sir.
சரி, right. Take home message.
Yeah, definitely excision biopsy. So many times I've burnt out.
Follow up with the antibiotics. If the child is improving, you don't even have to do anything.
And if you
FNAC
need
at this age should be avoided.
Definitely excision biopsy.
Like Pavai Madam mentioned, you at this age you think of some congenital anomalies like branchials and all that.
FNAC is a simple procedure, can be done as OP.
Can be done, sir, but sometimes so many times, recently now only I have a child. It was treated as granuloma TB because of FNAC showed a granuloma, but we did an excision biopsy.
It sometimes misleads you, Balaji. That's why.
Yes, madam. I'll accept.
As long as it
that
helps
cannot
you
be a
find
representative sample.
Yeah. Okay. Move on to the next patient. Yeah. Tirumurugan, we have one more or two more?
Deepa?
Yes, sir. One more, ma'am, if I'm right.
Yeah. I think Ilamati, Ilamati has to.
She has done.
ma'am. No, ma'am, no, sir.
Learning from that. Okay.
Ilamati has not done because I remember the name soon.
Yeah.
Ilamati has to present.
Yes, ma'am. I will present.
Yeah. Share your screen, Ilamati. Ilanidhi, sorry.
Ilanidhi is now. I mean,
Ilanidhi.
Can you just rotate your mobile, doctor?
Yes, sir.
No, you turn it around to landscape, not to the side, so that it will be fully visible.
Okay.
Yeah, thank you.
Yeah, go ahead, Ilanidhi.
It is 7 months old female infant admitted with the concern of left-sided neck swelling for past
at last
2
one
days.
left side, all right side.
Yes, sir, left side. Left side. History of presenting complaints. 7 months old female infant, apparently normal, developed fever for 7 days, which is low to high grade fever, intermittent, no diurnal variation, which is relieved on taking medication.
Hey, two devices you have logged in, huh, doctor?
Wait.
There's an echo when you're present. Log out of one device.
Okay.
Please proceed.
Fever workup was done, which showed fever workup was done, which showed elevated CRP and normal. The infant was clinically active. Then the infant became afebrile after 2 days of antibiotics. After that, baby developed left side neck swelling, which is noticed by her mother for 2 days. There's no history of weight loss, no history of contact with the tuberculosis, no history of contact with the pet animals, and no history of travel. Then clinical features: infant was well nourished, alert, afebrile. Hello, sir. Okay, sir.
No, you carry on. I think that was something else.
Balaji, mute pannunga. Balaji, mute.
Vitals were stable. No pallor, ictus, cyanosis, clubbing, edema, no secondary lymphadenopathy. The left-sided neck isolated 3 into 3 centimeter size swelling noted in the posterior triangle, which is firm in consistency, freely mobile, tender, and warm. Head-to-toe examination normal. ENT examination also normal. Then investigation showed leukocytosis and CRP was elevated. Mattock test is negative. Neck showed hypoechoic collection with echogenic sediments in subcutaneous plane in posterior aspect of neck on the left side, which is closely to the inferior surface of the parotid glands, likely to be the infected lymph node or subcutaneous abscess. So the maybe differential diagnosis may be the cervical lymphadenitis and is infection from head and neck, or tuberculous adenitis or subcutaneous abscess. Then we treated the infant with IV antibiotics and analgesics. The insertion and drainage was done by the pediatric surgeon. 4 ml of thick pus was aspirated, ma'am. Then first sent for the microbiological and histopathological test. The gram staining showed the gram positive cocaine clusters, and pus culture showed staph aureus, methylene sensitive staph aureus. Then as it was, gene expression was negative, ma'am. Clinically, infant was stable, so in febrile, so she was discharged with oral antibiotic, ma'am.
Yeah. Again, similar to the previous case. Yeah.
Yes, ma'am. Diagnosis left cervical lymphadenitis, ma'am.
Torticollis was not there, but
yes,
again,
only neck swelling alone.
What antibiotic was given?
Amoxicillin, ma'am, and amikacin, ma'am.
Here it is emphasis only, no? We can narrow down.
Yes, ma'am.
Is an ideal choice.
Okay, ma'am.
Amikacin,
amikacin is not.
Okay, ma'am. Okay.
Again, very small child, 7 months old.
Yes, ma'am, 7 months, ma'am.
Was there any scalp infection like?
No, ma'am, nothing, ma'am, nothing like that.
No
only
seborrhea,
cold
no
cough, ma'am.
discharge.
No, ma'am. No, ma'am. Everything's normal.
Because no, very unusual for children less than 1 year to get such bad infective adenitis. So have a close follow-up, try to look for focus of infection in the ear, in the scalp. And sometimes even head lice they may have, you know. Mother from the mother, they can get a head lice. Yeah. Lice infestation is quite, I mean, it's little not often thought of, but it is not uncommon. It is common.
Okay.
Anything you want to add, Dhanalakshmi? I think that was a straightforward child. I don't think we have anything to discuss. Only thing is,
Madam,
I think we can, any other case, Tirumurugan?
Madam, I want to stress on in such cases of acute lymphadenitis, except for the course of antibiotics, or on the investigation side, maximum ultrasound and a course of antibiotics is more than enough, I think. Because otherwise, FNAC and whether gene export and other things, I don't think it is necessary in an acute case.
You wait for 2 weeks of adequate antibiotics, adequate dose, adequate duration, the right dose, right duration, right choice has to be given. The 3 Ds, no, you have to do all that. And then if the child, because most of the time when we have, because ours is a tertiary care, already they would have received antibiotics for 3-4 days or 1 week also, and then they'll come to us. But the dose would have been inadequate and the choice would have been not an ideal choice. There is a proper algorithmic management of a child with cervical node. I think you look at foci for any local infection. If there is nothing, I think you should give a good course of antibiotics, preferably amoxicillin to cover staph and strep pneumonia. And we'll have to wait and see whether, of course, you are going to examine the child as a whole, look for organomegaly, look for other red flags like anemia, bleeds, and other things. I mean, you're not going to miss a malignancy. If the child does not improve after 2 weeks of adequate antibiotics, and then you probably go ahead, do a MANTO, do a fasting gastric aspirate. Usually we do all those investigations only after that. If there is local tenderness, that means that there is an pus inside. That's another clue. So when you examine the child, there is tenderness, you're happy because it's more of an infection. If there is painless node, you always get worried. You think more of a lymphoma and other Kikuchi and other things. Painful, always think of infection. Treat, and if the child does not improve, I think the next thing is excision biopsy. And then, of course, your other parallel investigations like MANTO, chest X-ray, fasting gastric aspirate, and all that. I think, Tana, you want to add anything?
The time parents might have noticed a small lymph node, maybe 1 centimeter, 1.5 centimeter. If there are no red flags, like no other lymph nodes,
Just leave them alone.
yeah, and without tenderness, we need not do anything. We just keep a follow up. You can reassess after 2 weeks, then you reassess after 6 weeks. If then we take a call. So small lymph nodes,
Non-specific tiny nodes.
most of the time react to
parents
lymph
get
nodes.
worried.
Yeah.
You just reassure them because no, they just think. I mean, if there is a node in the neck, immediately they think of malignancy. Parents immediately think of tuberculosis or malignancy. More than tuberculosis, they think of malignancy because somewhere some relative or someone would have got treated. They get worried and very difficult to reassure them. That is the most tough job.
But before that, all the red flags should be ruled out. Look for other nodes, look for organomegaly, look for pallor. So if nothing is there, we can reassure and just keep under follow-up. We can counsel them if the node increases in size, if the fever comes or anything, then we can manage accordingly.
And
Pawai
I think
wants to say something. Pawai madam wants
Yeah.
to say something.
Yeah. Only thing is, see, whenever there is pus, it's better to remove it.
Yeah, that's what.
That's number one. Number two, if you see an abscess on the left side of the neck, please don't forget your BCG abscess.
Yes, correct.
Please stop the slide sharing, please.
Agreed, ma'am. Yeah. So I think small infants, like 2 children were less than 1 year. I think those children, you'll have to be little close follow-up is required for these children because normally infective adenitis is usually seen in an older age group. Smaller infants with isolated node causing so significant to cause torticollis, keep a close watch. Do not miss any underlying problem like immune deficiency.
And
LCH can present like that. LCH and HLH, all those things can present like that. So have a close watch on them. Yeah.
Madam, to reiterate Dr. Pawai madam's thing, BCG abscess and BCG node particularly, usually it will be left supraclavicular, actually supraclavicular node and supraclavicular abscess rather than the deep cervical or posterior cervical. Usually it is that is the thing we have seen. We have seen one case also. The thing.
Yeah, it's quite common. Now we are getting BCG applied, I mean, faultly administered in the thigh, and then we are getting abscess in the thigh and all. And when you do an incision drainage, you get tuberculous bacilli in that. Yeah. So sometimes that too happens.
Suppose a node recurs in the same site, think of anatomical problems, bronchial cleft abnormalities.
Yes.
Yeah, thank you. And through all presentation now.
I think all of them presented. Yeah.
I think everyone is presented.
So, on behalf of IAP TNSA, really thankful to today's moderator, Dr. Janis Shankar Madam, and Dr. Dhanlakshmi, and Senior Pediatric Surgeon, Dr. Pawai Madam. And hello?
One more case is there, sir. One more case is there.
Yeah,
Ilanidhi.
Come on, sir. Dr. Deepa.
Hello?
Deepa presented, no?
Yes, sir.
Sherina.
Ilanidhi பண்ணாங்கன்னு தெரியல.
Ilanidhi present பண்ணிட்டேன் சார்.
Sorry.
Deepa from Dharmaburi is pending, sir.
Okay, please.
Sorry, we'll go ahead.
Short case only, sir.
No, from Dharmapuri already there was a case. 2 cases.
So there are 2 cases from Dharmapuri, ma'am.
Okay.
Yeah, please proceed. Okay.
Sorry, yeah, please.
Thank you, sir.
Good evening, sir. I am going to present a case of 12-year-old female child with cervical lymphadenopathy came with complaints of fever on and off for 2 months, tiredness for 2 months, and weakness and not active for 2 months. History of presenting illness, history of fever for 2 months.
Your slides are not moving. Your slides are not moving. Deepa?
Sir.
Your slides are not moving.
Click inside the slide, yeah.
Slides are ponga.
Click inside the slide, ma. Click inside the slide to start moving.
Is it visible, ma'am?
No, it's not moving. Visible but not moving. Go to the next slide.
Sorry, can you just go to enable editing right at the top left? Enable editing, just click on.
Yeah, click that. Yeah. The cursor doesn't seem to move.
Yeah.
Yeah. Make it very brief.
Yeah, please go.
12-year-old.
And then now you go to the PowerPoint presentation, Mona, F5 or PowerPoint.
Fever for 2 months.
That's right. Yep.
Yes.
2 months. Treated with paracetamol. Okay. Myalgia.
12-year-old child with female child with cervical lymphadenopathy came with the chief complaints of fever on and off for 2 months, tiredness for 2 months, dullness and not active for 2 months. History of presenting illness, history of fever for 2 months on and off, which is high grade and intermittent, not associated with chills and rigor or no diurnal variation. Each time the child is investigated with CBC and fever profile and treated with oral antibiotics and paracetamol with some local practitioners. For that time it is input, and again the child had fever in a gap of 4 to 5 days. History of tiredness plus for 2 months, history of myalgia plus for 2 months, history of arthralgia plus for 2 months, history of vomiting plus occasionally, no history of cough and cold or breathlessness, no history of diarrhea, abdominal pain, no history of headache, altered sensorial seizures, no history of night sweats, weight loss or loss of appetite, no history of any rash, no history of hair loss, no history of bone pain or no history of bleeding manifestation. Past history, no history of previous hospitalization, no history of significant previous illness in the past. There is no contact history with the TB patients, and the child is immunized up to age. On examination, the child was conscious oriented but dull and lethargic, febrile, not dyspneic. Mild pallor was there, no ictus, no cyanosis, no clubbing or no pedal edema. Related cervical lymphadenitis plus, each of size 2 cm, just soft, discrete, which is not matted but and not painful. History of the bilateral axial lymphadenopathy plus 1 or 2 nodes of size 2.2 cm, which is also soft and not painful. BCG score was there. There is no rash, smaller rash, or no, there is dental caries. Vitals, heart rate is 98 per minute, respiratory is 20 per minute.
Table, you say that. I mean, you don't have to go through all that.
Temperature was
Tell the significant things alone, ma'am.
Yes, ma'am. Perabdominal examination, mild hepatomegaly is plus of liver span 14 cm, mild splenomegaly plus. In investigations, mild pallor was there, which is 9 grams per deciliter. Thrombocytopenia, 1,03,000. Peripheral smear shows no evidence of immature cells or no cell lines. CRP was negative. Procalcin is also negative. All fever panels, malaria, dengue, scrub, brucellosis, leptospirosis, were negative. Manto and CB-NAT was negative. Chest X-ray shows no evidence of hilar lymphadenopathy or TB. US abdomen shows mild heterosplenomegaly. Blood culture, urine culture shows no growth. ESR is 9.
Stop, doctor, stop. Chest X-ray, no evidence of hilar lymphadenopathy or TB. What do you mean by that?
No specific findings of TB. No
effusion. You cannot mention, you cannot tell that, okay, because you're a student. You cannot talk. I mean, hilar adenopathy itself is a manifestation of tuberculosis or miliary mottling or cavitation. You cannot say that no evidence of hilar lymphadenopathy or TB. I think that's not a correct term. Okay. Okay, go ahead. Go ahead.
ESR is 98 mm/hour. Positive finding in my case is it is adolescent girl with prolonged intermittent fever with malaise, myalgia, and arthralgia. Bilateral cervical and axial lymphadenopathy is there with mild hepatosplenomegaly. In investigation, mild pallor, mild thrombocytopenia, significantly elevated ESR, and all infective panels were negative.
Anemia also.
Stop here.
There is anemia.
Some discussion here.
Bicytopenia.
Yes, ma'am.
Yeah. Bicytopenia with elevated ESR, negative CRP. First diagnosis is SLE. First rule of
SLE and some, yeah. Infections get ruled out because CRP cannot be negative and it is infection. Yeah.
And yeah, proceed.
Go ahead.
DCT was done. Huh? DCT. Direct Coombs test. No.
Okay. Go ahead with the but other investigations.
Tuberculosis, leukemia, lymphoma, and inflammatory conditions. Since a biopsy of cervical and axillary lymph node shows non-specific reactive lymphadenitis, no feature suggestive of malignancy or TB. As the child is having discordance between ESR and CRP, want to rule out SLE. Have done double standard DNA, ANA profile by immunofluorescence method, came positive for SLE. Anti-Smith antibody is also positive for SLE. It is a case of cervical lymphadenitis with the PUO turned to be autoimmune disorder, systemic lupus erythematosus. Rheumatologist opinion obtained, confirmed the diagnosis and managed as per the protocol. After that, the child improved. Take-home messages: cervical lymphadenitis is important clinical finding in daily office practice. Analyzing all the clinical features with basic investigations will give direction to arrive the diagnosis. And strongly positive, positive, strongly elevated ESR and negative CRP.
Yeah.
Thank you.
Okay. Thank you. So again, yeah. So you have to correlate the clinical condition with the investigations. Here, ESR and CRP gave you a clue, and adolescent girl comes with fever itself, we think of SLE. Of course, tuberculosis has
then proceed with the dsDNA. Need not do everything for all patients.
Okay.
Yeah. DCT is very important. You should have done DC. That gives you.
Okay. Adolescent girl anemia, urine routine, ophthalmic examination.
Yes.
Yeah.
Okay, I think we had a variety, Dr. Rajendran. I think we had variety. We had one tuberculosis, one SLE, one Kimura, and one Kikuchi, and two infective staphylococcal adenitis. That was a variety, and I think all presenters did justice to their presentation. All of them were very crisp and clear presentations, and
well presented, madam.
Yeah, I think the discussions.
Can you stop slide sharing?
Yes, sir.
Can you stop slide sharing? And because of IAP TNSA, I thank our today's moderator, Dr. Janani Shankar, and I thank Dr. Pave Madam and as well as Dr. Dhanlashmi, who has done extremely very well. And actually, they presented nicely all 6-7 cases that it was went on very well. And I really thankful to all the presenter to make this possible. And once again, on behalf of IAP TNSA, I thank all the listeners as well as learners also. And over to Dr. Thirumurugan sir.
Thank you very much, sir. I think we had a very exhilarating session, and thanks to Janani ma'am, we are pretty much on time. Just a rare occasion with this 4C series. So thank you very much, ma'am, and thanks to our experts today, Dr. Pave ma'am and Dr. Dhanlashmi.
Dr. Kannan has raised his hand, I think. Thirumurugan. Dr.
Yes.
Kannan, sir.
Yes, Dr. Kannan, do you want to say anything before we close?
Yeah, as a radiologist, I want to make small points in this forum. So all they did the investigations at the ultrasound net. There are few features are there actually to diagnose, and there are standard reports are also there. So like a infection, there are clues that so there will be the perinodal infiltration will be there in the ultrasound. So that will give the clue it's a infective cause. So we need to follow it for the intranodal abscess suppurative one. And this Kimura and Kikuchi, that Kimura will shows the hypervascularity nodes. It will shows the hypervascularity source, and there can be a subcutaneous mass lesions. So that will be the one clue. And the CT, it will shows the hyperdense nodes for Kikuchi and Kimura. So there are few findings or favor these nodes how to proceed with the radiological also. So that's what I want to make. We can
Thank you, sir. That made it complete. That made it complete. Thank you. Thank you, sir.
Thank you.
So thank you very much, sir. Apologies for your request to give your comments. So thank you very much, everyone, for joining us. Again, we had a fairly good audience and some very interesting cases.
We had 7 cases, Thirumurugan.
Yes, ma'am, which is more than 7, but still you got it on time. So thank you very much, ma'am. And very some common and uncommon cases. So and some practical elements as well. So all in all, it was a very all-round.
On time.
So, but before I conclude, we are still going to have one more again this by the end of this month, because the one due for October. So hope to see you soon, and of course we will have our weekly or bi-weekly dose of our postgraduate clinic. So thank you very much, and hope to see you in the next program.
Thank you. Thank you, Rajendran and Thirumurugan.
Thank you,
and
ma'am.
Suresh.
Thank you, sir.
Thank you. Thank you, ma'am. Thank you,
Thanks,
Dr.
Dana, for
Thank you.
valid points. And Pavai, madam, thank you so much. Your points were very, very valid. Thank you,
very
ma'am.
much, ma'am.
Thank you.
Thank you. Good